All right, everybody. Well, thank you for your patience there. Sorry we're getting started here just a couple of minutes late, but everybody's got a camera on their computers these days, and we certainly don't want to see too much background information. This is designed to be a literature review for the cervical and the lumbar spine and some of the treatments that we use. So if you don't mind, I'm going to go ahead and get started right now. And here we go. So just a little bit about me. My name is Jonathan Small, Doctor of Physical Therapy. I'm the Director of the Central District for the NYPTA. I did get my doctorate's degree out of Utica College. I am the owner and operator of Everybody Physical Therapy in Herkimer, New York, and I've dedicated my practice and specialized in spinal care for the last 3 years. And I typically utilize the Maitland methods as far as mobilizations are concerned. There is no financial obligation or promotional items disclosed in this presentation, so let's get started. Quick anatomy review. This should be a review. We'll go through this quickly. There are two types of natural curves of the spine, the first being the primary, which is a kyphotic curve or flexed curve. That is in the thoracic and the sacral spines. There is the secondary curves, which is the cervical and the lumbar spines, lordotic or extended. There is the nucleus pulposus and the annulus fibris. Muscles of the spine, we have the global movers, we have the local movers, our global movers, the rectus abdominis, the iliocostalis lumborum, the local muscles, the transverse abdominis, the multifidi, the erector spinae group as a whole.
Not sharing.
Nervous system. It looks like there may be some difficulty seeing my the slides on the presentation. If that is the case, I apologize. We'll make sure that this gets posted for your viewing pleasure later. Talking about the nervous system, we have afferents, we have efferents. That's how our body receives and perceives information. Going through the cervical spine. Cervical spine is the only segment of the spine that has one additional nerve root as the C1 exits from the occiput into the first cervical vertebrae. We're working our way down 12 thoracic nerve roots, 5 lumbar nerve roots, 5 sacral nerve roots. A little bit about the prevalence of cervical spine. Those who work in outpatient, they can certainly relate to this. 20 to 50% of the population will experience neck pain during their lifetime. Staggering figures. Even more staggering to that is that approximately 47% of those individuals that will result in chronic pain within 1 year. So attacking these situations, at the first time that they come into our clinics to try to avoid that percentage, it speaks volumes with what we can do as physical therapists, and as we try to get away from this opioid epidemic, we are on the front lines. We want to make sure that we have the ability to go ahead and treat these individuals right up front. Caucasian women, they do unfortunately have that increased risk. It's estimated that approximately 7 to 22% of women versus 5 to 16% of men. I'm going to go ahead and take just a quick break here, just one moment. And that's our short intermission. Sorry about that. Getting some pings through mobile devices with my two audience members here. Possibility of some sound difficulty. Again, this will be recorded. We will post this presentation for you as well, but to be respectful of individuals' time, we're going to go ahead and keep right on moving. Talking about the prevalence of cervical spine pain. Again, unfortunately, the 4th and 5th decades of our life is when these symptoms are the most pronounced. Sedentary office-based workers have that increased risk. look at this office worker here. You'll see it on the presentation if it's not showing right now. This is what we do. This is what I did while I put this presentation together. The use of technology, think about the way that we navigate on our phones, how long we play on our phones, think about what that does to our spine, think about the positions that we're in, etc. And approximately 25% of all outpatient physical therapy patients are usually cervical in nature. So again, that's a huge financial burden. It's time off of work, it's missed wages, it's healthcare benefit money. Some common conditions of the cervical spine that we will see frequently walking through our door: cervical strains, which is muscular strains, cervical degenerative joint disease, degenerative disc disease, spinal stenosis, facet joint syndrome, WADS, whiplash-associated disorders, cervicogenic headaches, forward head posture. All of these things, forward head posture has the ability to enhance what we see as far as the conditions that come along with these individuals with neck pain. So treatment methods of the cervical spine. On the front lines, what do? We have manual therapies. We have mobilizations. We have manipulations. We have soft tissue mobilizations, myofascial release techniques, IASTM, instrument-assisted soft tissue mobilizations. We have therapeutic exercises, kinesiotapes. We have movement therapies. Your movement therapies being Tai Chi, yoga, Pilates. We're going to talk about each one of these and what the evidence tells us because, again, we have limited amounts of time with these individuals. If you haven't made that call to your congressman regarding the hard cap for Medicare, please make sure that we do that before the 19th, but we have limited amounts of time to work with these individuals. We have to be as effective as possible. We're going to talk about manual therapy in the form of mobilization and manipulation first. It's hypothesized that there are two main mechanisms for the hypoanalgesic effects. It could be the gate theory or the reduced afferent discharge. So basically that's being modulated through the spinal cord, or we have the descending inhibition of pain, which is the periaqueductal gray and the efferents. So the dosage of immobilization, remember, just like all other exercises or treatments that we do, we have to have a measurable objective, so a grade, a rate, an amplitude, how many reps, how long are we doing it for? So Schmidt et al., he performed a meta-analysis that investigated the effects of mobilization versus no treatment at all. No treatment being education, and that's about it during this study. And approximately 20% of individuals will improve just with a mobilization alone. So we have to put our hands on people if that's the only thing that we do. We have to make sure that that we are at least doing a thorough passive mobility assessment and treating the affected vertebrae appropriately. The use of thoracic spine thrust manipulation in addition to non-thrust mobilizations to the cervical spine. We have to remember, we have to look at those adjacent joints as well. So again, looking at a randomized controlled study here, Mazzaricchio evaluated 64 patients with mechanical neck pain. All right, they broke that down into two separate categories. We have a group that received cervical non-thrust mobilizations along with a home exercise program. And then another group that was randomized with high-velocity thrust mobilizations or manipulation to the thoracic spine, coupled with non-thrust cervical mobilization along with home exercise program. Basically, what was determined is that there are significant improvements based upon the Neck Disability Index, as well as the numerical pain rating scale in the experimental group. Substantial changes. So, looking at baseline, talking about the NDI, the Neck Disability Index, pretty consistent. Those who were in the experimental group had an approximate rating of 28.5%. Those in the control group, 26.3%. That's at baseline. Now, post-treatment, we're looking at a 16-point change based on that NDI. Again, valid, reliable assessment here, a 16.2% change by adding that high-velocity thrust mobilization to the thoracic spine, coupled with a very effective home exercise program and non-thrust mobilizations to the cervical spine. So again, making sure that we're not only just treating the area where the individual's pain is, but also moving to those adjacent joints as well. Results improve with level-specific joint mobilizations in the cervical spine. So again, that is different, and that is a very interesting article. I'll refer you to the reference list. That is very different from what the literature says for what takes place with the lumbar spine. High mobilization forces are more effective compared to low force mobilizations with the reduction of stiffness throughout the spine. This study, again, it determined that there's no difference with high and low force mobilizations for the reduction of pain. This one specifically is talking about stiffness, hypomobility throughout the cervical spine. The interesting thing here and the interesting follow-up is that the changes in the stiffness were noted 4 days later. So again, it's not immediate impact. This is something that, on follow-up sessions, asking those questions, taking those objective measurements, not just at evaluation and re-evaluation, et cetera. Get those goniometers out and assess, treat, assess, and treat. Are your treatments effective? Manual therapy, talking about soft tissue mobilization. Again, APTA launched many hands-on techniques, and that list is ever growing at this point. So manual therapy along with exercise has reduced pain and disability compared to manual therapy alone or exercise alone. So, in my practice, typically what I will do is I will start working on people, prep the tissues, and then take them through exercise. We know that as we start to work those tissues, thinking about actin and myosin, thinking about how those fibers are actually oriented, you want to prep those for work. We know, we become stronger in the line of force that we exercise in. So again, prep the tissues, work the tissues, and that's where we're going to have good effects. You can't do one and not the other. Multimodal approach that has demonstrated improved cervical outcomes with cervical radiculopathy. Again, 11 randomized subjects here. The treatments, they included neuromobilization, cervical traction, myofascial inhibition techniques, basically to the upper trapezius, sternocleidomastoid, supraspinatus, infraspinatus, scalenes, rhomboids, pec minor, subscaps, suboccipitals, all the area, the periscapular muscles, we have to work on those because, again, you can't just treat the area that's where the pain is. And what this study, what it showed us is that there was improved functional disability and reduced pain. So again, there's a small table on here. The neck pain disability scale, 0 is maximum pain, 0 is no pain. You can see that people started off with a relatively moderate amount of pain, 36 on that. This is an average, but post-treatment, again, using those techniques with radiculopathy, you have the ability to take that person down to approximately 11.45. Looking at the visual analog scale, 7 out of 10 pain. We know what that feels like. We know what that looks like when somebody walks in. To be able to take them through an effective program, not just treating, soft tissue, or not just treating the spine itself, but looking at this person as a whole, mobilizing those neural structures. Post measurements at a 1.18 as far as the visual analog scale. And again, shoulder abduction, looking at 9.2 at baseline. Is that even moving the arm? And then taking this individual to 137 degrees. That's a pretty substantial difference. That's the difference between functional, non-functional, doing our hair, brushing our teeth, etc. So therapeutic exercise, obviously this is what we do. This is what we guide people with. Therapeutic exercise meta-analysis was performed by Oridian, which included 16 studies with regards to the frequency, the intensity, the type, and the time of the exercises that are being performed. It's going to start off with the frequency. Studies have shown that there's positive outcomes with 2 to 3 times per week with decreased pain and improved quality of life. Subjective but objective. I mean, these are patients or participants that are telling us that their pain is less and they feel like their quality of life has improved. With a follow-up with this study, 12 weeks out, it looks like their adherence rate to the home exercise program was approximately 39%. We as therapists, we want to make sure that we get that number up, making sure that we're providing home exercise programs, whether it be email, paper handouts, whatever the situation may be. We know what the literature tells us. We know how people benefit from these things. We need to make sure that that they're doing what they're supposed to do as well. Intensity. Yelinin demonstrated improvements with both resistance and low-intensity exercise and chronic pain. Resistance, we could talk about how to grade resistance from a strength and conditioning standpoint. There are various different ways that we will go about that. But this study specifically defined resistance exercises as 20 to 70% of the maximum voluntary contraction. So, that's our responsibility to try to help those, our participants or our clients to find that optimal exercise resistance for maximum benefits. Also define low-intensity exercises is simply going against gravity. Going against gravity, what does that do for us? We have to think about that from a motor learning and a motor planning standpoint. It's not always about strength. We always want to take into consideration that, timing, coordination, those are very, very important pieces to the overall movement pattern and the organism as a whole. Also recommended 5 to 7% increase once you are able to complete 12 repetitions with good form. Again, studies are the same study here showing us that there's a 34% reduction in pain at both 6-week and 6-month follow-up based on this criterion here. The picture that's here, again, I put that specifically with the therapeutic exercises. We know the negative consequences of poor posture. We'll talk about that when it comes to patient education. But again, we need to strengthen those inhibited muscles. This is why we fall into these positions, and we need to reduce the tone in the facilitated muscles. Again, keeping with the concept of therapeutic exercise, again, looking at the meta-analysis here, concluded that benefits can be observed with as little as 10 minutes of exercise 3 times per week. What do you prescribe to a patient with their exercises? Are we giving them 10 exercises? Are we making this like a gym exercise routine? We have to understand that individuals who suffer from, we're going to talk about chronic neck pain right now, but we're also going to talk about chronic back pain here momentarily. But, those individuals can't tolerate 25 to 30 minutes of exercise. We need to be quick. We need to be concise. We don't need them to fatigue. We certainly don't need compensation patterns. So, interesting fact that, again, study can show that as little as 10 minutes of exercise 3 times a week can show benefits is pretty significant. Short duration interventions demonstrate immediate changes in pain and perceived disability. So again, understanding that people can exercise anywhere between 2 to 20 minutes and have positive effects on what they're able to do as far as what their pain is concerned and what they perceive as their disability. Understanding that it takes 6 to 8 weeks to build muscle strength. Are we giving them enough time? So we have to make sure that when we prescribe an exercise program and we try to keep it within a short period of time for them to perform it 3 to 4 times a week, we also have to make sure that we explain it to them that in order to have good benefits and see a significant improvement as far as strength is concerned, we have to allow that exercise program to go approximately 6 weeks. Types of exercises, combination of resistance, endurance, stretching, that has the greatest benefits. We talked about that with the previous slide. We have muscles that are tight, we stretch those. We have muscles that are weak, we have to strengthen those. When we start getting into the stabilizer muscles of the spine itself, those are our endurance muscles. So we have to train them for the job that they're responsible for. We don't train a baseball pitcher the same way that we train a linebacker. So again, we have to train our muscles for the function that they're designed for. Neck and shoulder stretches have demonstrated a decreased neck and shoulder pain and improved function. Again, taking into consideration those adjacent joints, thinking about what happens with the scapula when we raise that arm, what happens to as that scapula starts to rotate a little bit, what exactly is that doing to the cervical spine? If we are hypermobile in a segment, is that trapezius going to provide a little bit of lateral shift? We have to think about all those pieces as a whole. Kinesio tape. I don't know if anybody utilizes kinesio tape. The evidence is coming. It seems over the last couple of years, we went from maybe several studies to just under 100 studies to over 100 to thousands of studies out there. So again, this is it's growing. The evidence behind kinesio tape is starting to come through. The concept behind kinesio tape is that it is described as correcting muscle function, improving lymph and blood circulation, reducing pain through neurological suppression. So Gonzalez and Iglesias demonstrated improvements in pain and range of motion immediately and at 24-hour follow-up. So again, we have 41 participants here randomized with whiplash-associated disorders. And basically what they did in order to randomize them, everybody got kinesio tape. However, half of that group got kinesio tape with the appropriate tension as prescribed, and then the control group had no tension at all. And basically there's moderate evidence to support that immediate pain reductions, although it's not fully understood. Okay, evidence is still coming through. There's lots of mechanisms. The mechanoreceptors as they're in the skin. Many different factors that go into the evidence behind kinesio tape. There is no evidence that I was able to locate with regards to muscle strength and long-term range of motion. There is, and we will talk about this a little bit more with the lumbar spine. It is not in the form of muscle strength, but it is in the form of improved muscle activation. All right, so maybe we have an inhibited muscle that's not engaging the way that it's supposed to. Evidence does support that the fact that kinesio tape has the ability to stimulate that muscle to get it turned on. Low quality evidence again at this time with regards to injury prevention. Okay, so we see our athletes with kinesio tape on there. The concept of motor learning, repetitive activities, trying to keep those pieces where they belong and move the way that they're supposed to. Again, low quality evidence at this time. Give it a couple of years, and I'm sure we'll have a more solid understanding about the physiology and why exactly kinesio tape is beneficial. So now we're going to move on to the lumbar spine. So again, lumbar spine prevalence, low back pain. It's prevalent in 75 to 85% of the population during their lifetime. Those are staggering figures. Again, we can think of if you think about today's roster, was there 50% of your clients coming in with back pain? If not, it's probably pretty close. So again, if the cervical spine at 20 to 50% was a huge economic burden, lumbar spine is right up there as well. Now this is a worldwide prevalence. This is just staggering figures. The precise cause of low back pain is accurately discovered in only 12 to 15% of those with back pain. So it's very possible that you put 10 people in a line, do imaging of them. It's very possible that there are going to be asymptomatic individuals who have changes to their spine. And again, asymptomatic. There are those who will have back pain, and their imaging may look okay. So again, that's where we as therapists, a good solid examination, history taking, all the things that we learn. We really want to make sure that we're hammering down on those things because they are very important. And we don't want to think about this most recent episode. We could talk about this from a cervical spine perspective or from a lumbar spine perspective. Motor vehicle accidents. You may have somebody in their mid-50s, mid-60s, childbirth. We have to take all of those things into consideration and how their body responded to that at that time. Is that a piece of the puzzle? So again, common conditions of the lumbar spine. Looking at lumbar strains, degenerative joint disease, spinal stenosis, degenerative disc disease, facet joint syndrome, herniated nucleus pulposus, and again, with the back, there are many complex factors that go into consideration here. All of these pieces poor lifting mechanics, squatting mechanics, sustained postures. There's always a concern with these types of injuries when it comes to healthcare providers, nurses. Doing those bedside treatments, drawing blood in unfortunate positions, 10, 15 minutes, maybe even longer. So again, we really want to make sure that we're taking a good, solid history and asking valuable questions so we can get the information that we need to appropriately treat these individuals. So again, in review here, we're going to talk about the treatment methods for the lumbar spine. They're going to look very similar to that of the to the lumbar spine here. It's going to look very similar to that of the cervical spine. We're going to talk about manual therapies, mobilization, manipulation, IASTM, soft tissue mobilization, therapeutic exercises, kinesio tape, and now we will put together cervical and lumbar movement therapies, again, yoga, tai chi, and Pilates. So manual therapies, mobilization, manipulation. Repeated sets of lumbar mobilization, that does have the ability to increase the pressure pain thresholds. So basically, Pentelka, what they did is they took 19 asymptomatic volunteers and used an algometer for pressure point threshold. And basically what they determined is that, some individuals were treated for two sessions of either 1 minute or 30-second intervals of mobilization. Some were treated after 4, and then as many as 6. And what they determined is that the significant change in the pressure pain threshold is after the 4th set of mobilizations. Mobilizations, again, that can consist of low amplitude, low velocity. So that's not your high velocity thrust mobilization. Kaltenborn, we have sustained mobilizations, or we can have Maitland with oscillatory, your grades 1 through grade 5. 60-second intervals had greater response than 30 seconds. And again, there's the neurophysiological effects can be found at the site of treatment in areas remote. So they did use the let me start that statement over. They put the algometer at various different locations on the body and noticed that even though they were doing mobilizations at the L4 segment, even up into the scapular region, they noticed that the pressure pain thresholds had increased. So again, looking at it from a global perspective and not just the area of pain. Good evidence to support joint mobilizations with exercises. Again, if we're talking about the spine, it doesn't have to be about the spine as a whole. Again, think about those glenohumeral joints, your patellofemoral joints, etc. But again, we know that mobilization is one piece of the things that we do. Exercise is the other piece. You combine them together, and world of opportunity for specific individuals who suffer from chronic pain in the spine. Ahmed et al. Demonstrated that 40 randomized participants, they had core stabilization exercises with mobilization. They had the ability to improve their self-reported pain and physical disability. So again, subjective but objective. These are the measurements that we go by. Oswestry scales, etc. This is what the patients are telling us or answering based upon their perceived disabilities. Pain reduction, again, has been shown with non-specific joint mobilizations in the lumbar spine. And this is where I wanted to point out that evidence does tell us that in the cervical spine, we do want to be specific towards the area of pain, regulating, how much mobilization force, focusing on those dose parameters. Whereas the lumbar spine, you can be a little bit less specific. Again, if it's your L4 that's painful, focusing on an L2, L1, and you can still have good pain suppression qualities there. Looking at soft tissue mobilization, randomized controlled study studied the effects of myofascial release with non-specific low back pain. 54 participants randomized 40 minutes of myofascial release versus those with a sham treatment. Now, the sham treatment was a faulty laser. So again, we want to take that into consideration. It is not the fact that they were pretending to work on somebody's skin. This is something that is completely different. However, if you have the opportunity to do myofascial release, soft tissue mobilization versus nothing, there are significant benefits from using myofascial release. And again, what they used here was a short form McGill pain questionnaire and the fear avoidance belief questionnaire. So again, getting valuable data based upon the treatment methods that were provided. Systemic review and the efficacy of soft tissue mobilization. What was determined that soft tissue mobilization is inferior to manipulation intent. We want to take into consideration. We talked about the gait theory. We talked about the descending pain theory. We want to make sure that we don't stimulate the body the same way through the myofascial system, the same way that we do with manipulations. However, soft tissue mobilization was superior to acupuncture and self-care exercises. We'll talk about self-care exercises and what happens there. We already saw that at a 12-week follow-up, only 39% are actually adhering to home exercises. So we'll talk about that here in the very near future. Therapeutic exercises, specifically geared towards the lumbar spine. So core and lumbar stabilization. We know that the internal, external obliques, multifidi, transverse abdominis, the pelvic floor, diaphragmatic breathing. We know the importance of these things. I decided not to go into great depth about that. There's a ton of literature with regards to core and lumbar stabilization, and we know the importance of that. But I broke that down to how do we activate the core the most? How do we get those structures firing the way that they're supposed to? We use steady and we use unsteady surfaces. So, the idea is that if we're on an unsteady surface, we're going to get more co-contraction of those global and the local muscles. Basically, what a study has indicated here is that when both the feet and the elbows, if you're performing a plank, both of those are on unsteady surfaces. That is where, through EMG studies, we have the most co-contraction between the global and the local muscles. You've seen bridges on the Basu ball. Basu ball bridging with the elbows on the Basu ball is as effective as planking on the actual floor. And again, we want to make sure that we're challenging individuals. If you think about that, what is the real difference when the feet and the elbow? And let's not reinvent the wheel here. When we are on unstable surfaces with both the feet and the elbows, you have the upper body, which is completely unstable, and you have the lower body, which is unstable. And the central point to stabilize is right there in the midsection. So, moderate evidence to support the use of breathing exercises. How many individuals truly attack that breathing mechanic on that first session? We can think about it from a relaxation standpoint. We can think about it from, we know that there's decreased respiratory function and decreased breathing patterns. So we want to make sure that we are addressing that as well. Focus on individuals breathing. Belly breather, are they using their accessory muscles? All of this is very important. What we have determined here is that deep breathing exercises, again, 10-second hold, in 10 seconds, holding it. We really want to focus on the pattern, the rate, and the volume, the difference in the lung capacity and the diaphragm with individuals with chronic low back pain. There is literature to support the alterations in the breathing mechanics. I'll talk a little bit about kinesio tape now for the lumbar spine. Ahmed demonstrated the improved activation of the transverse abdominis, a reduction in pain intensity, and improved functional disability when compared to exercises alone. So again, 90 participants, randomized. KT tape promotes normal muscular movement and aids in realignment of the collagen. So again, I predict that over the course of the next several years, we'll have more evidence with regards to the physiological changes that take place and why these results are the way that they are. The application of KT tape has demonstrated a reduction in movement-related pain avoidance, confidence. I've had individuals specifically where you put it on and you're thinking, well, I don't know if this is really when they come in and they say, hey, you know what, I felt better, and if it can help keep somebody in a good upright position instead of slouch forward, we get those erector spinae muscles facilitated. Only good changes are going to take place there. Quality, 39 chronic low back pain randomized to control tape. KT tape, KT tape with exercise or just exercises 3 times per week for 4 weeks. Important to know that all three improved. We would expect that. However, the exercise improved the most with their perceived levels of disability. And that's based upon the Roland Morris Disability Questionnaire. Also interesting to know that, again, using EMG studies, that 28% of those who had kinesio tape applied to them along with exercise, they had improved lumbar muscle activation. So again, you're talking about 28%. If we think about that from our patient client, that's half of our chronic low back pain patients that come into our clinic per day can potentially benefit just by reactivating those muscles. So let's talk a little bit about the movement therapies. Again, with Tai Chi, yoga, Pilates, etc. We have to bear in mind that we have to make sure that these are appropriate modalities, appropriate exercise modalities for our individuals to know your population, know what their strengths, what their weaknesses are. We certainly don't want to make anybody do something that they are not comfortable doing or are not physically capable of doing. Lausch did a randomized controlled study, 114 participants with nonspecific low back pain, and basically what they showed, they went with treatment versus no treatment, and again, significant improvements with the use of Tai Chi versus no treatment at all. Tai Chi, it's a low-impact mind-body exercise that originates from China, integrates dynamic musculoskeletal, breathing, and meditation training. So again, just becoming more in tune with your body. What's it feel like to breathe? What's it feel like to get that diaphragm, rising and falling? What's it feel like to have those muscles in the back engage as you go through slow, controlled movements? Interesting to know about Tai Chi as well is that it is no more effective, well, at least this is what the evidence tells us at this time, is that it's no more effective than neck strengthening exercises specifically. Take that into consideration, but also think about those individuals who have plateaued. We want to have different tricks up our sleeve. If we have pulled out all the stops for an individual and they're just not getting better, what's wrong with an attempted Tai Chi? Again, there is evidence to support it. That could be the barrier that really helps somebody break that plateau. Yoga, again, physical postures, breathing techniques, and meditation. Again, these are slow, controlled, organized movements. It does have the ability to improve balance awareness and motor control. Kramer et al. Demonstrated that yoga proved to be more effective for pain reduction when compared to home-based stretching program. And again, this is with 51 patients. We have to take into consideration when you do yoga, if it is in the form of a class yoga, we make sure that individuals don't go beyond their capabilities. Understanding that muscle strength, muscle length, that will improve with time, but they are at least in a structured environment where we can keep an eye on them, and advance them appropriately. Home-based exercises, again, we advocate for that. But if you have the opportunity to do a structured yoga versus simply telling somebody a stretching program and sending them on their way, the structured yoga has proved to be more beneficial. Pilates, again, looking at the Pilates methods, 6 basic principles: centering, concentration, control, precision, fluidity, and diaphragmatic breathing. The consistency between our three movement therapies is that breathing component. We talked about the breathing exercises. It takes 5 minutes or less to teach somebody the proper breathing mechanics. People can focus on proper breathing mechanics all day, every day, and that can make a real big difference for individuals. Again, Pilates, it focuses on core stability, posture, flexibility, strength, and movement control. 2 types of Pilates. There's the traditional method, which is utilizing with machines. You're bouncing, a little bit less control there, and then modified methods, which is basically, your mat-based Pilates. Currently, there's low-quality evidence to support Pilates method for pain reduction with chronic low back pain. However, there is evidence to support. Again, we look for high-quality evidence. With time, as these treatment ideas and methodologies continue to improve, I suspect, again, that we will end up with more higher grade quality evidence to support Pilates. And again, it's not, right now, it's not conclusive that Pilates is more effective than other forms of supervised exercises. However, Again, if we have the ability, if we have somebody who's really plateaued, and it happens with the low back, individuals, they get themselves to a certain point, maybe they don't feel like that they can go any further. This is movement-based. This is going to keep people engaged. It's going to challenge their body in a completely different way. This could be the one piece that breaks that barrier. Again, we talk about Pilates versus home exercise program for postmenopausal osteoporotic women. 2 times a week for Pilates versus thoracic extension. This was a 1-year study. And again, both interventions, there was improvements. We expect that, if we take somebody who has chronic pain, decreased movement patterns or faulty movement patterns, once we start to challenge that in an organized way, low grade, really start to challenge people in a respectable way and challenge their bodies, we expect there to be benefits. But in this case, Pilates was superior to the thoracic extension exercises alone. Equipment exercise, Pilates demonstrated improved perceived disability compared with mat exercises. There's no change in the pain perception, though. But again, if you have somebody who can tell you that I feel like I can do more, I still have pain, but I can do more, that's a plus for us, and that's a plus for them, and that's what we want. The science behind that, again, you put somebody on a piece of equipment, it puts them in a little bit more control. The challenges are there. We also want to make sure that it's successful for them as well. Patient education. This will be our final topic here for the evening. Patient education, we can't overestimate the overall importance to educating our patients about all the things that we just talked about. Why are we doing what we're doing? How does it benefit them? Cognitive functional therapy with exercise therapy is demonstrated to improve patient outcomes both long and short term. Okay, so again, why are we doing what we're doing? How does this benefit you? We have to think of pain not only as from a mechanical standpoint. There are many components that come down to pain: physical, cognitive, psychological, lifestyle, neurophysiological, social. We have to take all that into consideration if we deem to be successful when treating individuals with chronic cervical or spine pain. The fear avoidance and lack of understanding and the exercise benefits. So again, that's our job. That's what we do. While they're going through exercises, tell them why they're doing it. Explain what's working, what's not working. Why are we making modifications? I tell individuals in my clinic all the time, I challenge you. Ask me why. Ask me why for absolutely everything. If I give you that deer in headlights look, it's probably not the right thing. If I can explain it to you to the T, I don't expect you to take a test on it. But if I can give you a good, solid understanding, chances are the compliance rate is going to go up. So again, we want to focus on the patient beliefs. We want to make sure that we understand what their fears are. How long has this person been dealing with pain? 20 years, 30 years? We want to make sure that we understand that fully. Education about pain patterns. Again, the periaqueduct gray, talking about, efferents, afferents, not to that magnitude. Obviously, we want to take that down a notch, but, understand and explain these things to individuals. Treat them like a human being and not just a low back pain with somebody who's been having pain for X number of years. And finishing up with patient education, again, what is the importance of adherence to the exercise program? We want to make sure that we are informing these individuals. Why are we doing this? What does this do for you? And again, that's really what it comes down to. We provide services as physical therapists, and we have to make sure that we do our services to the T. There's good therapists, and there are not so good therapists. We want to make sure that we take these people's situations very, very seriously. Postural awareness, again, we talk about postural awareness pretty much all day, every day in my clinic. Sitting, standing, computer, playing on your phone, whatever the situation is. I have no more joy than to find somebody sitting on the bike playing on their phone with 30 to 40 degrees of cervical spine flexion. I love that. We get to talk about that too. Lifting, squatting mechanics. Again, before somebody's discharged, if they can do a partial squat, that's one thing, but can they lift a laundry basket? How's their mechanics? Put a load in their hand, see what it looks like. Those are there needs to be that carryover. Again, we talked about the pain mechanisms. Obviously we want to take that down to an elementary level for our patients. Don't put the wow factor in using big words. They don't care about that. Smoking cessation. We don't. When I talk to individuals about smoking, it has nothing to do with what it does to your lungs and your cardiovascular system, although we'll toss that in there. But that's right there on the cigarette pack. What does it do to your healing? What do we know about the evidence as far as, the calcification and changes that take place to the disc material with those who smoke? Our ADLs, we want to make sure that we take all of those things into consideration. Previous example, squatting is one thing. Squatting with a ball, squatting with, stimulating, picking up a child. What does it feel like to engage your core while you try to give an infant a bath? There are certain activities that, we can only modify so much. There are many activities that put us in a naturally bad position. Everybody will ask, how do I give my child a bath in a tub? And, that's unfortunate that you're going to be in a pretty bad position there. But if we can let them know what it feels like to, engage and stabilize that spine, instead of having your erector spinae, bring yourself back into that neutral position. Fire the glutes, let that hip extension take place. Those are just small pieces, but very, very valuable pieces to individuals who suffer from chronic pain, whose systems aren't completely functioning the way that they're supposed to. There's a long list of references. This will be available here for you. And I do want to thank everybody for their time on a Wednesday night. I hope everybody's trying to stay warm out there. And if you do have any questions, you can go ahead and type those in, and we'll get right on top of those. I would like to also provide my email address if anybody has any questions. Sorry, I'm getting feedback here. I would like to give you my email address in case there are any questions. You can also reach out to me that way. Please allow me 24, 48 hours to get back to you. Is doc, D-O-C, small, S-M-A-L-L, at Everybody Physical Therapy, EVERYBODY, physicaltherapy.net. Thank you.